All right, so welcome to the Diabetes and Obesity Collaborative Lecture Series. Don't forget to sign up on the attendance sheet right here, and then at the end please do the evaluation.
See, I recruit some other people to learn a little bit about that.
So we have the honor of listening to today's lecture, Understanding Diabetes Glucose App and A1c, presented by Dr. Uzma Khan. She's a professor of medicine in the Department of Medicine, Division of Endocrinology here at the MU. So Dr. Khan started at MU in 2004. And then she's a board certified endocrinologist, and she has a practice at the Lake, right? Center, Cosmopolitan International Diabetes and Endocrinology Center, right? Is that at the Lake? She's also working at LSP Scheller in our hospital, and she has been involved in several collaborative projects around diabetes too, involving mobile app development, measurement of glucose using Raman spectroscopy, as well as ethnic and gender disparities in hemoglobin glycation. And she actually using the continuous glucose monitoring and mass spec hemoglobin quantitation. Thank you for coming to our series.
Thank you very much for inviting me. I just realized I think there's a mic hanging from the ceiling, and it's working, I'm hoping. So again, thank you very much for inviting me. I'm a pure clinician, so it is very nice to have an audience that is from a totally different field of medicine, but is just as important in healthcare. This is the official title of my presentation. Understanding diabetes, a big, vast disease, and maybe understanding glucose and apps and A1c. But here's the alternative title. What is it that takes a clinician and makes the clinician a 5% researcher? And what do I mean by that? When I started out at MU in 2004, I was 1%. Of my time was research. And after 14 years as a clinician, 95% of my time is clinical and 5% is research. So I think that's an important concept, because it's always hard when I'm talking to researchers to explain to them, I don't have the time, because my time commitment is towards clinical experience. But I also like free lunches. And I think that is what got me from the 1% to the 5%. And we'll talk about that just a little bit. The objectives of this presentation are basically very poorly defined as far as I'm concerned. But I hope by the time we get done with this, you will have some concept about diabetes education. Also the limitations in our assessment and education of diabetes for patients and providers both. And then areas for future collaboration. And this is to translate all the research that's being done from the cell level all the way to the most latest technology, and how to take that and use it to not only focus on one person, but also the public, and then also the providers. And if you notice, I've included researchers that might be doing basic research, and Dr. Fay is definitely a clinician, but maybe researchers in his lab. You are part of the team that provides care to all these millions of diabetics that are being diagnosed every day. Diabetes used to be a disease of high blood sugar. But I think everybody in this room knows that we are just putting the pieces together right now. It's not just hyperglycemia anymore. We have beta cell dysfunction, we have insulin resistance. We even know that the kidney's ability to hold on to glucose, or the renal threshold for glucose, is impaired in diabetics. Intestinal uptake is impaired? Genetics, and then what are the other hormones? What are called the GLP-1s, the new medications that are coming out, that are addressing the incretins, which are a type of hormones. And then there's another set beyond that, and that is the blood glucose, the glycated hemoglobin. And then what about exercise and diet? And we still have all these other things that are coming in as we learn more about this very, very complex disease. So anymore, it's not just a high blood sugar. The problem is we don't understand what we're talking about. And we also need to keep in mind that the day a patient, a person is diagnosed with diabetes, that day the person has a chronic disease, we don't have a cure for it. So he's told, you've got this disease for the rest of your life. There's a total lifestyle change. And it's very, very hard. Imagine yourself as limiting your carbohydrates, limiting your sugar, limiting your portion. Just a total lifestyle change for us. And then the fear of complications. Your feet are going to be cut off, your eyes are going to go blind, your kidneys are going to fail, and you're going to be on dialysis. And then the patient is responsible for it. It's almost as if you caused your diabetes, now you take care of it, otherwise you're going to have all these bad complications. And I just don't agree with the way we do diabetes at this time. And the more patients you see with diabetes, the more you interact with them, you realize you're not doing the right thing. There's a very, very large body of research, and I'm not going to present that today. And then just based on my daily clinical experience, what I do know is the things that are very hard to measure. What's the psychological impact? And if anybody is doing that, I'll be very happy to talk to them. How are we measuring this impact on our people as well as our society? And then the financial burden. We have big calculations, but it's also for the person and for the society and for future generations to come. And then as a society, how do we deal with it? These are very hard to measure. So as time goes on, starting from my fellowship and then clinical practice and not having a basic understanding of the pathophysiology of diabetes, I started realizing I didn't understand things very well. Now, not having any experience and any exposure to basic science research, I thought maybe what I could do is start trying to at least understand a few things about diabetes that I can do my own learning for it and apply it to my patients then. So, first of all, the thing that affects is the glucose. The day the patient is diagnosed with diabetes, I'm giving them instructions about what to do about their blood glucose. So I need to know how to do or understand the glucose myself. The instructions the patients include that are given are, you're supposed to check your finger glucose, you're supposed to write it down, and then based on that information, I can tell you your blood glucose better. Most of the time they check once a day, but if they're insulin or if they are uncontrolled, having low blood sugars, high blood sugars, they may be checking their fingers 6 to 8 times, sometimes even more. And just imagine doing that for every day.
Long distance to mute their mic so that noise doesn't come through your.
So, Dr. Simoes is saying there's somebody whose mic is not muted on the other side. So if you could please mute your mic because we're having an echo coming from it. Thank you. And then they're supposed to come for regular clinic visits. And again, they're going to have serious complications. The burden is on the patient. This took me to the first, that's why I bring the free lunch. There was a very nice lunch. It was, an email was sent out. I had time that day and I went and I was sitting next to a very interested group of researchers, Dr. Kenan and Dr. Upendran, and they said, you're interested in diabetes? We're interested in diabetes. So that's where this first project got started. And basically what we did was we looked at a non-invasive way of checking blood glucose. And what we used is what's called Raman, R-A-M-A-N, laser spectroscopy. And this is a very interesting project. The first time I had an opportunity to actually participate, starting from how the project was built up, how we collaborated with MIT, how the patients were recruited, how everything was done. I think it was just outstanding how the rest of the team was very patient with my questions. And we've now got a publication, and basically what we did was we conducted a pilot study. So the Raman had already been designed by the MIT laser team. And what we did was we did the pilot study in a clinical setting. And we had participants, 23 healthy non-diabetic patients. Actually, that was one of the criteria. We wanted to take the fluctuating blood sugar out of the picture. We wanted to just show that this method, which is non-invasive, is as good as the invasive method. So that was the reason why there were patients that may have had the metabolic syndrome. There were patients that may have had impaired glucose, but we excluded diabetics from our, which is why the fasting blood glucose value had to be less than 125. Those that were qualified were given a glucose tolerance test, a standardized glucose tolerance test. And then we had 3 ways of checking the blood sugar. One was the Raman, then we also had the regular finger stick glucose monitor, and then we also had the venous blood glucose that was performed. So 3 measurements were done all at the same time. And then based on those results, we were able to see how well it performed. This is just to show you what it looked like. Actually, if you look at it, so the wristband is specially designed. It's actually quite snug. And it's fitted in there where you have the probe that's held at the same tissue point. And then it's quite snug, it fits there. And there's a fiber optic cable that goes to the spectrograph. And then there's a computer that analyzes it. The whole machine is as big as a grocery store cart. So it's standing, the whole thing is standing right there next to the patient. And the patient has this wristband on for 2 hours. This is the readings. And again, I can tell you that the glucose tolerance test I can show quite well, but the Raman findings, I am not very educated about it. I'm learning it myself. But we found out that we can actually correlate this really well. And we were able to show, based on our findings, that this non-invasive mechanism is as good as doing the finger sticks for these patients that don't have diabetes. So these participants that did not have diabetes, it's as good as doing a finger stick. Okay? And the important thing was, even when we decreased the need for calibration, it still stayed accurate. So that is, again, a very important thing to keep in mind. So with this small project, that was one of the first ones I did related to diabetes, what did I learn? The first thing was, it's surprising that me as an endocrinologist, I actually knew that there was a difference between venous and interstitial and capillary glucose. I actually had to go and read about it, which is so, it just tells you that, we think we know everything, but we don't. And then there's a different thing called the optical glucose measurement, which is, again, a totally different thing. I also realized that finger sticks are not fun. And some of the participants that did not even have impaired glucose were actually quite expressive about the fact that finger sticks are not fun. But then having your hand compressed for 2 hours is not fun also. So although we have a really good machine that is as good as finger stick, does not require calibrating, we need to take some further steps. And I think that's the way we conduct our education, our research is we do a study and then we take the next step. So I hope that in the future, based on our findings, we will be taking that next step. So that was the part about understanding a little better about blood glucose and then use it for my patients. Going on to the next part, the A1c. Now, this is what is the standard education taught to endocrinologists about A1c. What is A1c? It is glycated hemoglobin, and we are all taught that red blood cells, they have a life of about 120 days, which is why you do the hemoglobin A1c every 3 months. If you check it less than 3 months, it's not accurate. And if the lifespan of the red blood cell has been decreased to less than 120 days, it is inaccurate. The glucose or the sugar enters the bloodstream, and then you have the glycation in the cell where the glucose attaches to the hemoglobin, and you result in glycated hemoglobin. This then is measured by the machine, and you can use that to indicate a person's control of their diabetes over a period of time and correlate it to complications. Okay? And that's the standard treatment, standard education we all receive, and we believe in it very strongly. Until the day you sit down next to a chemist, and you're sitting next to a chemist, and the chemist says, "Oh, you have an interest in diabetes." And I say, "Yes, I do." And he says, "Well, tell me about hemoglobin A1c." And I say, "What do you want to know?" And he says, "So, okay." And then he starts talking, and it's a foreign language to me. I don't understand what he's saying at all. So actually, again, I have to go back. And I say, this is all very interesting what you're saying. And he's proposing a project to me. And I'm embarrassed to tell you, I don't understand what he's proposing to do. So I say, this sounds so interesting. Could you write down your name and I'll get back in touch with you? So I go back and I study a little bit. And then I start realizing what he was saying. I say, what? It does sound interesting what he is saying. And then we start an email interaction. And that's when I learn that actually there's hemoglobin A, which has the 2 alpha and the 2 beta chains. And then there's an A0 and A1, and there's a totally different thing which is called total glycated hemoglobin. Okay, so you have that also. And then A1c is just one out of all of these. And no wonder Dr. Stoyanov was telling me that when you're measuring just the A1c, there may be situations where you are missing other products, or there might be a difference in how different people are doing this. So that took us then to, should we do something to clarify what an A1c is? First of all, the testing methods are different. Standardization is still being worked on. And then we don't understand the biological variation. So whether it's gender or racial. We know there's a correlation with complications, but that's about all we know. Is it really the A1c that correlates with it, or is it something else? Is it just a marker? Okay? And then the relationship with finger stick glucose, as well as the new sensors, what are called the glucose sensors, that a patient can now put on themselves, and then they give them an average glucose over a period of time. How do we correlate all this new technology that's coming up? So that led us to designing another study. And what that was, that although glycated hemoglobin, which by the way now I know includes A1c, because there can be other glycated hemoglobins, is used as a marker for the term for hyperglycemia in patients. We usually measure it by a boron affinity method. But that method assumes that there is no variation based on age, sex, or race. But we do have an excellent method by LCMS that we think may be more reliable. And just around this time, there was a very nice opinion piece in the Annals, where the Department of Defense and the VA, after doing some extensive, they have lots and lots of records available for review. What they found is that there is evidence on a population basis that African Americans have higher A1c levels related to self-monitoring of their blood sugar. And then we know that NIDDK already says that consider that all the lab tests that are available, they represent a range rather than an exact number. And that be very sure what assays you're using and consider each patient. Thing is, what do they mean by that, consider each patient? So we got more interested in it and we thought, you know what, we're going to do a small study. So we designed a small study, a learning process again, very complicated language that we worked on here. And what we did was we had a continuous glucose monitor that we used, and we compared the results from that using mass spectrometric A1c quantitation. This was very interesting because we wanted to look at ethnic and gender disparities in hemoglobin glycation. The study was designed to be done at the University in Columbia, Missouri. We were looking for African American, Caucasian, and men and women, so a small group. We were looking for 40 patients, 10 in each subgroup. We ended up with only about 30 patients. And can somebody guess why we ended up only with 30 patients? We forgot that it's not as diverse a population where you might be able to find enough African Americans to participate in a study like this. So our main deficiency was we were able to recruit completely for the Caucasian subgroup. We were not able to recruit completely for the African American group. So it was again a very good learning experience, and if anybody has an interest in looking at and has an African American population, we will be very happy to collaborate with that group and see what we can come up with. What we did was we excluded patients that are on insulin in this study. And there were two reasons for this. Number one, because it was a small study, we did not want to deal with the significant glycemic variation that is in that patient group. Number two, there may be something about glycation of proteins that is different when you're treated with insulin and not treated with insulin. So theoretically, there's a difference, which is why we excluded patients that were on insulin. For each patient that had that we recruited, they got a CGMS, which is the continuous glucose monitor, and then we analyzed that, the mean blood glucose from that, as well as the finger sticks and the A1c, and we did them at the first entry and then within a 3-month period one more time again. So we had 2 data sets for each patient, and we had device support from Medtronic. It was a very, very good thing for us that we were able to get this test done. And what we found, we are now looking at the preliminary data from this, is that if you look at A1c versus the mean blood glucose, there is a little bit of a tendency towards saturation, which basically means it's not a graph that keeps going on and on and on. So as there is saturation, there may be a difference that we are probably not taking into account when we are looking at A1Cs and the long-term risk of complications. There was also an unexpected difference in men and women. So we were not able to look at the racial differences because we did not have enough diversity, but we did have a slight tendency towards male and female. The difficulties we had in this one, again, did not have a good understanding. Inexperience, I would say. We learned from our experience about the population demographics. We were also having problems with calibration, and that is something I shared with one of the people that is aware of the Medtronic CGMS, and my understanding is that is something already been identified and is being improved. And then we have made some of the experiments we did. We tried to make some changes in things. So as we moved along, we made a few changes in. We also introduced the concept of differential glycation index. There are people working on this concept already. And I think we want to take that concept to the next step, to where we can actually integrate that into the care of each patient. So it's very good to have a differential glycation index that researchers know about. But if the clinicians don't even know what you're talking about, and we cannot use it to improve the care of the patient, I think it is almost useless to have that knowledge then. So the next project that we hope to gain from once we are finished with this project is we want to develop a new platform where it's not just the A1c, it's not just the blood glucose, but maybe we can look at the person. What's the gender, maybe even the age of the patient, maybe the race or ethnicity of the patient, and then see if we can bring together this idea of the differential glycation index that we can use. And we want to explore all of this and then use it in clinical practice. Because again, it's like if a tree falls in the forest, the noise it makes nobody hears, but if you put a big pebble in a nice lake where there's everybody watching, we'll see all those waves. So I think it can be a small thing, but may make a big difference if we can take it to the audience. So that was my part about the glucose and the A1c. But now we come to the next part, which is about education. Diabetes is a disease that's not going anywhere. In fact, I was talking to one of the younger people that are now going into diabetes in the audience, and I said, I'm so glad by the time it becomes this major problem, I'll be retired and enjoying myself doing some small projects, and these young people can then take the lead on maybe curing diabetes. Who knows? Even back in the 1920s, we know that diabetes education was considered very important. Then in the 1970s, it was identified as something where the medical community needs to be involved. And this article is from 1995, emphasizing the need for diabetes education. The patient is the one who controls the diabetes. And the long-term education should be every step of the way when it comes to diabetes. Another interesting dynamic that's happening now is, and this is data from 2015, and the cutoff they have is at the age of 64. And to me, I think that even when you look at that, we've got 30 million diabetics between the ages of 18 and 64 in the US. Out of those, we have 17% that are above the age of, between the age of 45 to 64, and then above 65, we have 25.2. But can you really say above 65, a 65-year-old person is the same as a 75-year-old person, is the same as the 85-year-old person, which is the life expectancy in the United States now. So we have this big group of people, 1 out of 4 in this age group has diagnosed diabetes. So what are we doing with these patients? This is what Medicare covers, by the way. So Medicare covers for diabetes education. But just look at this. Conditions for coverage of diabetes education. The training must meet 3 conditions. Must be ordered by the provider, who should have a comprehensive plan of care. It must be reasonable and necessary. How do we define reasonable and necessary? The beneficiary must receive the training and have certain criteria that they meet also, which is that within the 12 months of diagnosis, they should have new onset diabetes. They should have an A1c of 8.5 or above. I'm not sure where that number came from, but by the time you have an A1c of above 8.5, I think you are way late in doing that education for the diabetic. If there's a change in treatment, if there's high risk of complications based on poor control, if the patients have a complication already, nephropathy, retinopathy, or neuropathy. But again, if you look at these, I'm thinking to myself, we are too late. If we are doing and paying for diabetes education by this time, we should be starting way ahead. Okay? And then here's the other part. What's the type of diabetes education Medicare is covering? There are two types. There's the only one time in their life, a diabetic can get this detailed initial education. Okay? And it's with 10 hours in a 12-month period. The first of these 9 should be furnished in a group setting and 1 hour individualized for the patient. An exception to the group if there is no group available or if the patient has some type of disability or special needs. Follow-up training, 1 hour, 1 year after the first training, may not exceed 2 hours. So the next year, second year of diabetes diagnosis, they get 2 hours of diabetes education covered by Medicare. And it must not be less than 30 minutes. So you can only do 30 minutes. Whereas sometimes I'm thinking to myself, do 4 times a year, but 15 minutes each time might be better. So I'm not sure how they came up with these numbers. I appreciate the fact that they cover it, but I'm not sure how they came up with it. Finally, the physician must document the specific medical condition that the follow-up training must address in both the referral for training and the beneficiary's medical record. Here's the thing. We physicians are already documenting too many things. And this is probably going to be the last thing we're going to even remember to document. So there must be a better way to do this. And that's where we come to the next part. And here, I'm going to really say thank you to one of our young PhD students. Ching was the one that got the focus going on this. I had no idea how big this problem was. I look at it every time and I appreciate the fact that PhD students go in depth with these things that nobody else has looked at and come up with really fascinating ideas. Over the last 3 years, she has presented her findings at posters and at meetings and has really done a fabulous job improving my understanding of this very important aspect in diabetes education related to people above the age of 65, but it doesn't mean it cannot be applied to younger people. So what is this area of interest? Starting back in August of 2015, and I can't believe it, doesn't seem such a long period, it seems much shorter. But starting around that time is when we first started looking at the apps that have been developed in mobile health. Because especially with this particular group of people, you know that mobile health and technology is the way to take care of chronic diseases in the future, as well as having patients live a better life. It cannot be where the doctor does everything anymore. We have now patients that have apps at home where they can diagnose diabetes. So why not embrace that technology rather than saying, here's the technology and there's the providers and we are two separate group of people. So I think that's what we need to do. So when we analyzed those apps, and it took us quite some time to do that initial app research, looking at both Google and iTunes. And the reason we use that is those are the biggest platforms that are available and the ones that are most commonly used by people. We identified the apps that fulfilled the criteria for diabetes education. And then we went through those and identified apps and what they dealt with. And the funny thing is, by the time in December, so we started out in August of 2015, and by December 2017, because this is an ongoing project, King had to go in and look at all the eligible apps once again, because some of them had retired and it was not valid anymore to be putting that in the study. So that is something very interesting for me, how rapidly this is changing. And in 2018, we are continuing that also. So what did we first do? We first did an analysis of the apps. And there is a very, very educated group of providers based on certified diabetes educators and as well as other healthcare providers with a focus on diabetes education. And they put together the AADE7, which are the principles for diabetes education, 7 principles that we should be employing for educating our diabetic patients. The funny thing is, even I didn't know the AADE7 because they are not part of endocrine fellowship teaching. Just tells you how we have all these little cubicles and we're all sitting in our own little cubicle trying to understand diabetes without talking to each other. So when we did this analysis, we found that most of the apps were dealing with healthy eating, being active, monitoring and taking medication. And very small number of apps was talking about problem solving, reducing risk, and healthy coping. So what we are focusing on is the minute today or the day today. We are not focusing on 10 years from now, which is when this patient is going to run into trouble. So all this mobile technology is focusing on today rather than 10 years from now. So the conclusion was future diabetes apps should attempt to incorporate features from this AADE7, which are validated principles that are easy to use and have shown to improve diabetes care to better support the self-management behavior of people with diabetes, because again, diabetes is not controlled by you or me, it's controlled by the person who has diabetes. So once this first step was done, then we take the second step. What is the user's perspective? So, just cancer. So there are 2 groups of users here that we're talking about when it comes to mobile health or technology in diabetes. One user is the person who's using it. And again, the focus was on older patients. So this was a very fascinating group we did. We created 2 focus groups. And in each focus group, we had one person that was the age of 50 or below. Now, because these were small focus groups, we cannot call that one person as the control. But we wanted to see how that person did, and we assumed this person grew up with more technology compared to people that were older. And then we asked them, how did you do? And we loaded those apps, we loaded several apps on an iPad and had them sit and then analyzed the information from them. And what we found from this focus group of people with diabetes is that current self-management applicants, they do not, all the apps that we have, they do not really provide evidence-based usable features for diabetes self-management, and they actually may not fulfill the needs for people that are older and have diabetes. Then the next step was, what about the providers? Because keep in mind, a person may be checking their blood sugar, may be using this fabulous app, but they walk into the doctor's office and the doctor has no time to look at that app and whatever information is available from all that hard work the patient has done. And in this one, what we did was, we first put together a multidisciplinary team of people that are interested in diabetes, and then came up with a short questionnaire. And we conducted a survey of 6 diabetes physicians. And again, it's a small group, just so that we can get an idea of what they might say. Based on input from the users, both the people with diabetes as well as the providers that take care of diabetes, we got some very interesting comments back. And they were really, really fun to read, and I put some of them down here. So one of them was the healthy eating, being active, monitoring and taking medication are all things that you can write down for problem solving. That's not easy to pinpoint. So everybody identified that then. Why did you not have breakfast? Because I got up later. Why did you get up late? Because I have 3 kids. So there are many variables in a person's life that these apps are not following. There is no human interaction. So our patients that are older, they love that human interaction. They want that human interaction. And I think it's up to us how we can create that, and that's something we want to put in apps for the older patients. The best one was when they had problems, Google was even faster than the app. Okay. In fact, I've heard Dr. Google being referenced to many times in my clinical practice. Then again, it's not black and white, concrete information, and everything is not based on numbers. I see many people with diabetes that are setting reminders in their calendars, and then people need, if you're asking them to risk reduction, if you're promoting smoking as something that should be stopped, then how to do that? What are the resources available? Then again, if a person cannot pay for services, why ask them to do those services? Because dentists are traditionally not very well covered. Dental health is important. Emotional needs was something that came up again and again. And then different cultures. I was interested to see that comment coming in. That, not everybody has the same approach to diabetes, and there's a cultural difference with these mobile health apps may not be identified. So with all of this understanding and finding, we have been able to put together quite a bit of information and promote it forward, and we hope we can continue to work on this. So we've published about the experience of diabetes self-management, about the analysis of the diabetes mobile apps, and then also how to evaluate apps for functionality and usability, and especially focusing on the older people with diabetes. What are the next steps? What we would like to do is, number one, focus on the providers. Because again, when I, as an endocrinologist, did not know this big gap in diabetes care, all these people above the age of 65 are not getting diabetes education. And we have a resource which is supposed to be available for them, but is actually not usable for them. Okay? So the providers need to be educated about self-diabetes management and AADE 7. Okay? We have to understand the increasing use of mobile health in healthcare for all chronic diseases. We need to learn how to use those mobile apps ourselves so we can teach it to our patients. And I think clinicians in every field, they need some gentle prompting. Because again, it takes, there are maybe other things we feel are more important, and this may not be our priority. The mobile apps that we are working on will be for what we call the silent generation. These are the people that grew up before the baby boomers and are not as aware of technology. So, and this is the group that is increasing and has complications. Also, social situations, physical situations that they have to deal with may be very different from other people. And then the people that may not have perfect vision and may have fingers that tremble. We should have apps that work for them. Okay? So, what about me personally? What did I think were the challenges when I stepped into research? And it had always been a very hard thing for me to do, because I think when we talk as clinicians, we speak a different language. Health informatics is a totally different language. Research is a totally different language. Writing a grant requires, I don't know what language it is. It's very hard to write a grant. And it's very hard for us to find that time. So for me, the thing is, what is it, this wide gap between the clinician versus the researcher? It's very, very hard to say it. It's just something that is there. And then gaining experience. Every time you're wanting to do something, you're supposed to have experience in it. Well, we don't have experience in it, but how do we gain that experience? And how do we find that time? And sometimes I think that is the hardest thing for us clinicians, and very hard to convey to people that might be spending 99% of their time on research. Publications are important. Now, for me as a clinician, they're not important at all. I'm doing this to improve my understanding of diabetes. But again, I think I was embarrassed when the reason why one of the teams I was working with was having a hard time getting a grant was this particular person identified as me did not have any research and had no publications. And what was I doing in that team? And I actually was probably pulling the whole team back because of that. Also, I think sometimes new content versus repetition. Why keep repeating the same thing again and again that I always find hard? And then I think I don't have to explain funding is always an issue, but it's good. It makes us work hard on clarifying our ideas and making them the best. What are the lessons I learned on this path? And it's been a fascinating journey for me. How did I get from that 1%, which was just there, to 5% research? Again, I really think now I make it, if I have the time, I'll go for a meeting or a conference, even if I don't know what they're talking about at all. I just sit in the back, I just listen to what they're saying, and this is what has, every time I've been introduced to somebody that's doing something. Also, I think just to do it. The project the ACT project is actually, we've been working on for more than 3 years, but the one that was from the MIT, it's a pilot study, a small one. It was very hard to get it going, but we did it. Same thing for the one we got from Medtronic. Same thing, very hard to get it going, but once we got it, we just did it. And then again, I don't think there's an idea that can be too small. I am sure if there's an idea that you find really fascinating, there's somebody out there that finds it even more fascinating. And then maybe we can come together and collaborate. And then the roundtable is really the best research tool. I really have to thank people that have worked with me in the last 4 or 5 years, because I will just sit there and I will have them explain everything to me. Because I sometimes have to go word by word so that they can explain to me what all they have been doing. So with this, I think I just want to, again, thank all the people that have really carried me into this small area of research. My mentors, maybe I really want to name Dr. Celso Gomez Sanchez and Dr. Jim Sowers, who are excellent clinicians, but the best researchers also. Then I want to thank the MU Office of Research, the MIT Lab, and the Medtronic's External Research Program, and then really my excellent current collaborators who are really working hard on educating me about how to move forward in this field. And who knows, maybe I might become a 6% researcher in the future sometime. So we have a couple of questions here. All of us know that diabetes is really a global problem. So I do hope that there might be people out there that will make it to where the challenge for us now is, instead of just focusing on when a person has had diabetes and has had complication, basically the house is on fire. I think rather than that, maybe we can focus more on understanding the basics of diabetes and then maybe preventing the complications that we all are going to see in the future. So thank you very much.